Good afternoon, everyone. My name is Xiangfei Meng. I'm the director for Division of Mental Health and Society based at the Douglas Research Center. So we are very fortunate having Dr. Marie-Josée Fleury and her team to bring us a very pertinent question on high frequent emergency use. And she and her team will discuss about the profiles, the needs, issues, and more importantly, also discuss the strategies trying to reduce the high ER use. So without further delay, I will pass the floor to Marie-Josée.
Yes, thank you, everyone. So I have a very big screen, so I'm not presenting with the show presentation. Sorry about that. So thank you first. I want to thank you, Xiangfei, for the organization of the conference division and for inviting our team. This is very appreciated. So we present today about emergency department use. So we got the CIHR research maybe 3 years ago. This research aimed to better understand all pattern of services use around the emergency department, and mostly we will talk about high emergency department, and I will also introduce you to this concept in a few minutes. So I will present today with my team, especially in fact with my students. So Bara Marmoun is doing his fellowship with me. Tiffany Shane is finishing a master with me. Firas Gattaz and Morgan Gabet have just finished for Firas his master and Morgan her PhD this early fall. And so I just want also to thank my team. 2 people are with us today as well. So Armelle Imbois, my coordinatrice for, I think, 15 years, and Guy Grenier, who is working for me, I believe, for now 20 years, and Zirong Sawa, our statistician, who is working with us for maybe 10 years. So I have a very stable team, very good team, and I'm very happy to have them with me. So why are we talking today about the emergency department? So the first thing to know when we think about the emergency department, it's really the only services in Quebec that is available 24 hours a day, 7 days a week. So it's the first services that patient when they are in crisis state, when also other services are not believed to be accessible enough, inadequate, or where patient are. When patients are missing continuity of care. We believe also that close to half of patients with mental disorder use the emergency department like an entry door to access services. So those patients have kind of incident mental disorder cases. So they come with a new mental disorder and they don't have any follow-up care in the community. Why also it's important to know about the emergency department? It's kind of the emergency department. It's kind of the barometer of the quality of the healthcare system. When the emergency department is overcrowded, it's often related to the fact that the healthcare system, the outpatient services, are not good enough. So there is, again, continuity of care problem, adequacy of care problem, access to care problem. We know that there is a lot of services in our mental health system that we have a long waiting time period to access those services. And especially when we see patient that goes and goes and goes often to the emergency department, it is this kind of problematic. So we call those patients our emergency department users. So when we look at the literature, there is no consensus about what is a high emergency department user. But we believe that patients who come at least 3 times during a year can be called as a high emergency department user. You know, going 1 time, we know that during a year, about 20% of the population. Il faudra que vous éteigniez votre Donc, so we know that there is about 20% of the population in a year that use the emergency department, but you know, going to the emergency department 1 time can be, you know, okay. going 2 times or going 3 times, we believe that it's more like, to be unlucky. So we did this research with the Institut National de Santé Publique a couple of years ago. We had the chance to work with them in their integrated database that it's called the CISSS. So it's a database that it's representative to the all Quebec population. So when we work with the CISSS, we work with, more than 8 million population. For this research, we first identified how many people were with mental disorder in the population. So we find 12%. And after that, in this research, what we want to understand is the pattern of services use related to the emergency department. When we compare patient with mental disorder to patient without mental disorder. And we were quite astonished to see that almost the double of people who have mental disorder use the emergency department compared to people without mental disorder. So we have almost 40% of people using the emergency department when we know that in the population it's more like closely 20%. So in this research, we find also that there were 17% of the patients with mental disorder that used the emergency department at least 4 times during this year of 2015. 2015. So they were called like high ID user, and even those people, we have seen that 1/4 of those people were visiting the emergency department on a long-term period. So 25% use were called like chronic high ID user, and they were using the emergency department from 3 to 5 consecutive years. We also know, if we look at the literature and also if we look at our own data, that there is a lot of people using the emergency department that could be treated more in the outpatient services. So between 25 to 40%, depending the literature, and those people in triage acuity scale, like in the Canadian triage acuity scale, they will be prioritized 4 to 5. So they're not a lot prioritized, and they could really be served in the outpatient services. So in our research, the objective of our research was really to better understand emergency department use, so determinants, profile of patient, quality of care after emergency department discharge or after hospitalization discharge, and we look at also we look the strategy that we can find to reduce emergency use. We also look at some specific group like patient with only incident mental disorder, patient with only substance-related disorder. We also look at patient coming to the emergency department for suicidal behaviors. In our study, we had close to 1/3 of those population with mental disorder coming at the emergency department with suicidal behavior. So in fact, in our research, we had like three arms with 3 specific objectives and methods. First, we create a cohort of 12,000 patients recruited from the emergency department in 2014-15 in 4 CIUSSS in Quebec. Patient had to have at least visit 1 time the emergency department during the year of 2014-15. We create here a 5-year cohort. 2020, so you have the year here. For this cohort, it's really a cohort based on administrative database that we can have from the Institut de Statistique du Québec. So the administrative database that is centralized through the Institut de Statistique du Québec, our FIPA, which is the sociodemographic database, RAMQ, which is the physician database, MEDECO, the hospitalization database, BDCU, the emergency room database, ECLSC, in ECLSC you will find psychosocial services, and also services provided by general practitioner working there. And we also have the RED database, which is the DEAD database. We published at this point 13 articles related to this cohort on determinants of emergency department use. We create also profile of hospitalized patient, As another example, we published a paper on profile of IID user, and Bahram will present you this specific paper. We also, so the second arm of our project was to create a survey. So we surveyed 300 patients directly at the emergency department. The idea of this arm was really to look at dimension not covered by the administration that is also this part. We want to understand better why patients were coming repeatedly to the emergency department. So we create a survey with questions not related to that we cannot find in administration database, and we link the information of the survey to the medical records that we can get from the CIUSSS. So in the CIUSSS, we can directly access to the BDCU, the Medico, CISSS, and also what it's interesting that we cannot get from the Institut National, from the Institut Statistique du Québec, is all the information related to specialized care, outpatient specialized care that we can get directly through the CIUSSS. We had also qualitative questions. So the survey was partly so open-ended question and closed-ended question. So we wrote here 5 articles. Here, for example, in one publication, we compare very high ID user to high ID user to low ID users. So very high ID user, here, there is also no consensus of what is a very high ID user compared to high ID user. So, but we took the definition of 8+ services here. Here it was more like 4 to 7 services here, and here was to at least 1 services to 3. The third arms of the project was to study the perception of the emergency department clinician and managers. This was a qualitative investigation. We surveyed 86 clinician and manager, and we want to ask them their perception of why patients were coming back repeatedly to the emergency departments. We wrote 2 articles, and Firas will present you one of those articles. For this arm, Tiffany will present an article on unmet needs. So, and finally, we published 2 literature reviews on strategy to implement in emergency department to reduce emergency department use and better respond to patients' needs, including a systematic review on high emergency department user, and Morgan will present you the result of this specific study. So now, Bahram, that will be your turn, but maybe I will just tell you how we will process for this presentation. So we will start just during the time that we will change the presentation. We can take maybe 1 or 2 short questions, and we will have maybe a 10 minutes at the end of the presentation to take more questions if you have any question. So Bahram, that will be your turn.
Hello everyone, I'm Bahram Armun. I am a postdoctoral fellow under supervision of Dr. Fleury. I'm going to talk about profile of high emergency department users with mental disorders. And first of all, I would like to acknowledge of all my colleagues, especially the supervision of Dr. Fleury, to conduct this research. Based on the literature review, high emergency department users usually defined as those making 3 or 4 or more visits per year, and they account for 21 to 28% of all ED visits. High emergency department users may reflect limited outpatient care or insufficient health services, and also they contribute to increased health care costs, and also high emergency department users may increase risk of death. High emergency department users tend to have mental disorders and also co-occurring substance-related disorders and chronic physical illnesses. So these population are so important to research, and to our knowledge, no study has elaborated to a typology of high emergency department users, including exclusively of patients with mental disorders whose patterns of service use may have unique features. We have 3 goals, and the first one was identify profile of high emergency department users that it was in our research 3 or more visits per year defined as high emergency department users among 5,409 patients with mental disorder based on their pattern of ED use and clinical characteristics. And the second goals of our study was identify sociodemographic and service use correlates linked to high ED use profile. And finally, we assessed the mortality risk in a 12-month follow-up period, controlling for sex and age. This 3-year study, 2013 to 2014 to 2015 to 2016 study analyzed data on 5,409 patients with mental disorder in Quebec. Our data sources were RAMQ, Medico, and BDCU, and we had 4 blocks of variables, and they were ED use variables like years of consecutive high ED use and dispersion of ED visits, and clinical variables like type of mental disorders and suicidal behaviors. And we used these 2 blocks of variable for creating the profiles. And also we had sociodemographic correlates like age and sex, and service use correlates like outpatient service use and hospitalization for association between each profile. And finally, we assessed risk of death between these profiles. We used latent class analysis for patient profiles, and also we used bivariate analysis for patient correlates over 2 years. And finally, we used survival analysis for risk of death within 12 months follow-up. We identified 3 profiles in our study, and the first profile was 3-year recurrent very high ED users, and we defined very high ED users in our study as patients who had 10 or more ED visit per year. And the first profile, it included 19% of our sample, and profile 2 was 2-year recurrent high ED users. It included 21% of our sample, and the third one is the 1-year high ED users. It included 60% of our sample. As I mentioned before, we used clinical characteristics and ED use pattern for creating the profile, and we found that the profile 1 was the worst profile. Nearly all profile 1 patient had 2 or 3 consecutive years of high ED use with 30% very high ED use. And profile 1 also had the highest rate of serious and common mental disorders, substance-related disorders, suicidal behavior, chronic physical illnesses, and personality disorders. Profile 2, for 67% of profile 2, ED triage priority scored high for either 33% to 66% of total ED visits, and for roughly half of profile 2 patients, yearly ED use was either very concentrated or moderately dispersed. Fewer than 1% were very high ED users, and the profile 2 ranked second for all the clinical characteristics like serious and common mental disorders, suicidal behavior, substance-related disorders, and chronic physical illnesses. Profile 3 was the best profile, and triage priority rates for ED visits were equally distributed, representing from 0 to 32%, and 33 to 66%, and 67 to 100% of total ED visits. For roughly 1/3, yearly ED use was either very concentrated or showed moderate or low dispersion, and the profile 3 had the lowest rate of common and serious mental disorders, personality disorders, suicidal behaviors, chronic physical illnesses, and substance-related disorders. And we also assessed the association between sociodemographic and service use correlate with each profile, and we found that compared to other profiles, profile 1 patient had lived in more materially and socially deprived area, and the intensity of care received was much higher for profile 1. It was 78%, and profile 1 patients were much more likely to have both a GP and psychiatrist as their main provider. It was 60%. And more profile 1 patient had been hospitalized. It was 67%, or frequently hospitalized. It was 21%. And frequently hospitalized in our sample defined as 3 or more hospitalization per year. Profile 2 were more older patient, and higher percent of profile 3 patients were without a usual physician provider. It was 26%. And finally, we assessed the risk of death between profile, and we found that the risk of death for profile 1 was 50% higher in 12 months follow-up period compared with profile 3, but it did not differ from profile 2. And profile 2 showed a trend toward higher risk of death. It was 41% more compared with profile 3, and profile 3 had the lowest rate of death. And we also found that death risk was 33 times higher for older patients, and women were 39% less likely than men to have died. We have several recommendations for each profile. For example, for profile 1, we recommended integrated mental disorder and substance-related treatment and home-based treatment. And for profile 2, we recommended assertive community treatment. And for profile 3, we recommended case management and increased physician follow-up. We also have several recommendations for all these profiles. For example, increased collaborative care between primary and specialized care and biopsychosocial services, more emergency department screening, and more brief intervention and treatment referral. We gratefully acknowledge the support of CIHR and Quebec Network for Suicide and Mood Disorder. Thank you. And is there any question?
So we can take 1 or 2 questions if you have it during the transfer of the presentation. So are there some questions at this point about this?
Yes, I have a question. Eric Latimer here. Thank you for the presentation. Very nice graphics. I was a little bit surprised when you jumped to the recommendations. Can you say just a little bit more about like how you go from the profiles to saying like profile 2 should get assertive community treatment? There are usually kind of specific admission criteria for programs like that that are not captured by your data. Thank you.
Yeah. For example, for profile 1, because profile 1 was 3-year recurrent high ED users, and they have more mental disorder and substance-related disorder problems, and we recommend integrated mental disorder and substance-related treatment, and for example, home-based treatment for them. And for profile 2, because profile 2 was the second ranked for mental and substance-related disorder problems, and also
Hi everyone, it's very nice to meet you.
And also they have ED triage priority score higher for either 33 to 66% of total ED visit, and we recommend assertive community treatment, and also we recommend case management and increased physician follow-up for profile 3, as these profile had the lowest rate of common and serious mental disorder and substance-related disorder.
Maybe I can just add to Eric that why we did that. For sure, in the administration database, those ones we didn't have the information related to if the patient have asserted community treatment or integrated case management or any of those programs. But we had this information for the arms that Tiffany will present, because we took all the information in the CIUSSS related to outpatient specialized services. But we base our recommendation on the fact that Profile 1 had really a lot of ED visits and hospitalization, and also it was recurrent. So those patients were coming repeatedly and again during 3 years at the emergency department. And those have also quite a lot of services compared to outpatient services compared to the older profile. But it's why we believe that they need maybe a better therapeutic alliance and more continuity of care. But we do not have, with this 12,000 cohort, the information about if those patients had really assertive community treatment or intensive case manager. But we have this information, like I say, in other research, and we can see that the patient that we survey in the emergency department, it's really just a minority that get those programs, even if they can be called as high ID user. So thank you, Eric, for this question. So maybe we will go on with Tiffany presentation, and we can maybe come back to your question, Eric, at the end of the presentation. So
thank you, that's good.
Awesome. Sorry. So just want to make sure everyone can see my screen all right. So my name is Tiffany Chen, and I am a second-year master's in mental health student at McGill, and I'm here to briefly present my paper on profiles of emergency department users with mental disorders related to barriers to outpatient care. So I will begin by speaking a bit about the research background, followed by the study objectives, then the study methodology, and finally the results, discussion, and conclusion. As Balam in the previous presentation kind of touched upon, ED overcrowding is a growing problem worldwide. It has been associated with increased wait times, morbidity and mortality, and decreased quality of care. High ED users have been historically targeted to reduce ED overcrowding and associated high costs. And patients with MD and SRD are amongst the largest contributors to high ED use. Since ED is more meant for urgent cases, they are not really an appropriate setting for treating recurrent patients or replacing outpatient care. However, ED users with MD, including high ED users, are a heterogeneous group and features distinct patient profiles, which suggests that personalized care should be adapted to these patients' needs. Unmet needs in this study is defined as the difference between services judged necessary to deal with health problems and services that are actually received. Several studies have assessed determinants of unmet needs among patients with MD and found unmet service needs was associated with being female, younger, and having severe or evolving symptoms or co-occurring MD, SRD, and poor physical health in general. Research in this area has also identified potential barriers to care. A barrier is defined as a health system feature and individual characteristics or behaviors related to patient unmet needs. Most studies sort of reported motivational or attitudinal barriers, like I prefer to manage things by myself. And a few reported structural barriers, like help is not readily available, as major reasons for perceived unmet needs among adults with MD. Yet no topology has linked profiles of barriers to care explaining unmet service needs among ED users with MD. Therefore, this study objective is to identify profiles of ED users with MD in terms of their perceived barriers to outpatient care and service use, and associate these profiles to sociodemographic and clinical characteristics. This will not only inform clinicians and policymakers on how to better respond to unmet needs of these vulnerable populations, but also help avoid ED overcrowding and misuse. Most studies have evaluated unmet needs broadly without examining the number of barriers to care. Profiles of ED users in relation to barriers to care, primary care, and specialized service use, and even patient satisfaction with care have not yet been reported. This study is thus original because it considers the numbers of barriers to care in relation to overall service use patterns among patients with MD, which may even explain their psychiatric ED use. The study was conducted in 4 ED networks in Quebec. Patients with MD, including SRD, substance-related disorders, who are 18 plus years and older, were randomly recruited through a list of 1,751 ED users identified by the network's ED staff. Of the first 563 eligible patients that were reached, 450 agreed to be referred to the research team to participate in the study. The patients completed a 45-minute phone survey in English or French. The surveys were administered between March 1st, 2021 and May 13th, 2022. The survey and medical records collected over the course of 12 months preceding patient interviews, except for recurrent ED use, which was a little bit special as it was measured over the 2 years prior to this 12-month period. Databases such as the BDCU, MedEcho, and outpatient hospital databases and the ICLSC were used to collect the data that was required. So the variables considered for creating patient profiles specifically included numbers of barriers to outpatient care, which was measured by one question in the Canadian Community Health Survey, the CCHSS. Patients were asked on a 5-point scale if services outside of ED responded to their needs. If they responded 1, which is totally disagree, to 3, which is somewhat agree, they were requested to identify barriers to outpatient care with 13 possible choices that could be associated with motivational barriers or structural barriers. The other service use patterns considered was having a case manager, number of consultations with GP, so a physician, number of primary care services other than with GP, and number of specialized outpatient care. Satisfaction with outpatient service use, high ED use, recurrent high ED users, and high hospitalization was also measured. Sociodemographic characteristics included sex, age group, civil status, stigma, and quality of life measured in the past 12 months. Clinical characteristics also measured in the past 12 months included MD, such as serious MD and common MD, suicidal behaviors, perceived mental/physical health conditions, MD chronic physical illness, which was more of the comorbidities, and percentage of high priority in ED triage, which was based on the Canadian Triage Acuity Scale. So now moving on to like the data analyses. Univariable analyses were conducted, and it utilized frequency distributions for the categorical variables and mean values for the standard deviations for continuous variables. The k-means cluster algorithm with the Gower dissimilarity coefficient was used to identify profiles of ED users. To determine the optimal number of patient profiles, several k-means solutions with different number of profiles were computed for cluster analysis. To determine the statistical difference between the profiles, pairwise comparisons were conducted using chi-square tests or Fisher-exact tests for the categorical variables, and t-tests or Wilcoxon rank sum tests for the continuous variables. For results, there were 450 users that were referred to the ED staff. 300 participated for a response rate of 75%. One patient was actually withdrawn through the process afterwards, so it resulted in a final sample size of 299. In terms of sociodemographic variables, most participants were women, aged 30 years old, single, perceived high stigma, and had a decent quality of life score. In terms of clinical characteristics, over half the participants had SRD, common MD, suicidal behaviors, and high triage priority. Over 40% had serious MD, personality disorders, or co-occurring MD SRD, or MD chronic physical illnesses. In terms of service use patterns, barriers to outpatient care were identified by 37% of patients, with 15% reporting 3+ barriers to outpatient care. Most had a case manager, consulted a GP, used 5+ other primary care services other than GP over the year, and 38% also consulted specialized outpatient services 5+ times over the course of a year. Mean satisfaction with outpatient service use was also high, and notably 61% were high ED users, 40% were high recurrent ED users, and 21% were hospitalized at least 3 times in the past 6 months. 3 patient profiles were identified. As you can see from the table, Profile 1 represented a large chunk, around 50% of the sample, and included the most patients without barriers to outpatient care, which was 87%, compared to Profiles 2, which is 68%, and Profile 3, which is 0%. Profile 1 also had the most patients with case managers and most patients that utilized primary care services 5+ times other than GP compared to other profiles. Profile 1 also included fewer high ED users, which is 58%, and higher recurrent high ED users, which was 37%, than Profile 3, which was 87% and 57% respectively. Profile 1 also reported the highest satisfaction with outpatient service use, which is 4.23 out of 5, which is similar to Profile 2, which was around a 4.07 out of 5. But it was significantly higher than Profile 3, which was only 3.46 out of 5. As a result, Profile 1 was labeled patients with low barriers to outpatient care and high primary care use, with most having a case manager. Accounting for 29% of the sample, Profile 2 had the fewest patients with a case manager comparable to Profile 3. Moreover, Profile 2 patient had not consulted a GP or used primary care services compared to the other 2 profiles. Profile 2 also had a lower number of high ED users and recurrent high ED users than Profile 3. Therefore, overall, it was given the label of patients with moderate barriers to outpatient care and low primary care service use. Accounting for 21% of the sample, Profile 3 reported the most barriers to outpatient care. They also consulted the most with the GP, had the lowest satisfaction with outpatient services, and had the highest number of high ED users and the greatest number of recurrent high ED users compared to the other profiles. As a result, Profile 3 was labeled patients with high barriers to outpatient care and high service use, including high ED users and recurrent high ED users who are not satisfied with service use. For associations between patient profiles and covariates, Profile 1 patients perceived less high mental health stigma than Profile 3 and had less serious MD, which was more common MD and suicidal behaviors than Profile 2. More Profile 1 patients also perceived good physical/mental health conditions compared to Profile 3, and their quality of life score, 4.54 out of 7, was understandably higher than Profile 3, but lower than Profile 2. Profile 2 included less women and also had fewer patients with personality disorders and co-occurrent MD chronic physical illnesses, and had more with good perceived physical/mental health conditions than Profile 3. Profile 2 patients also had less common MD, suicidal behaviors, and more ED users with lower triage priority, having a better quality of life than the other 2 profiles. However, they did have more patients with serious MD compared to Profile 1. Profile 3 also had more women, but overall compared to other profiles had the most women. They also had the most personality disorders, common MD, suicidal behaviors, and co-occurring MD, SRD, and physical illnesses. But they also had less ED triage priority than Profile 2. More Profile 3 patients also perceived high stigma compared to Profile 1, and fewer of them perceived good physical/mental health conditions and higher quality of life than the other profiles. In summary, out of the 299 patients, barriers to outpatient care explaining unmet needs were identified by 37 patients who used ED. It is interesting to note that 87% of Profile 1 reported no barriers to outpatient care. This could be explained by their high use of primary care services, and the majority of them having a case manager. Having a regular source of care and receiving biopsychosocial services were both previously associated with fewer unmet needs. Case management is also well known to help patients access outpatient services that adequately respond to their needs. and therefore could explain their low barriers in the first place. Comparable to Profile 3, Profile 1 patients had more common MD, which explains their high primary care use. Primary care settings often serve as like the first and only point of contact for individuals with common MD. And patients with Profile 1 also perceived having good physical/mental health conditions and quality of life than those in Profile 3. Overall, all of these may explain low barriers to care, as previous research has found that fewer unmet needs or barriers to care was associated with higher self-rated health and quality of life. 2/3 of Profile 2 experience moderate barriers to care. Of all the profiles, Profile 2 showed the lowest use of primary care services, but its high ED use and elevated satisfaction with care was very similar to Profile 1. Profile 2 were mostly men, had the highest percentage of serious MD, but the lowest ED triage priority. Also the least amount of suicidal behavior and the highest quality of life. Previous literature has shown that men are less likely than women to seek mental health treatments, which may explain why Profile 2 shows less high triage priority in the ED. And their high ED use with lower triage priority could be explained that the fact that patients with serious MD have reported receiving less primary care than patients with common MD in the literature. Moreover, studies have shown that patients with serious MD usually demonstrate better quality of life compared to those with common MD. According to the literature, patients with serious MD can lead to a good quality of life, despite their chronic illness, as they often carry fewer expectations, especially if they receive the help they need. In summary, Profile 2 report the best quality of life and perceived mental/physical health conditions, along with the least high ED triage priority, all of which explain why they received moderate barriers to care. And finally, accounting for 1/5 of the sample, Profile 3 had the most barriers to outpatient care despite their high service use. Comparable to Profile 1, less of them reported having a case manager or using primary care services other than GP. They also showed the highest number of ED and recurrent ED users and reported the least satisfaction with services compared to the other profiles. These service use patterns may easily explain high barriers to care, as high and recurrent ED users are found to be linked to insufficient or inadequate outpatient care. The fact that patients were less satisfied with service use report was also not surprising, as satisfaction with care is also a really key patient outcome. Profile 3 also included more women, which are known to use mental health services more often than men. And Profile 3 and 1 also shared very similar sociodemographic and clinical characteristics. But Profile 3 perceived more physical/mental health conditions and quality of life of worst of the three profiles, and they felt that they were more stigmatized than Profile 1. This could be connected to Profile 3 also having more patients with personality disorders and suicidal behaviors. The association between the poor perception of health conditions and greater unmet needs are also well documented within personality disorders and high ED users. So this study has a few limitations. Even though we use the unmet needs and barriers to care found in the CCHSS, unmet needs were not really measured on a standardized scale and were self-reported, which introduces bias. Second, the number of barriers to care were examined, but we did not investigate types of care such as information, counseling, medication, or types of care, which was motivational structural, which would have been adding more context to analyses and recommendations. Lastly, patients were recruited from a large urban psychiatric ED network in a public healthcare system. So the study findings might not be able to be generalizable to other settings. So lastly, in terms of conclusion recommendations, to our knowledge, this study was the first to identify a profile ED users in terms of their perceived barriers to outpatient care, service use, and associated sociodemographic and clinical characteristics. As a result, Profile 1, what we can do to reduce ED use is to improve access to after-hours primary care, patient education, and crisis resolution, and also improving coordination of care. For Profile 2, a recommendation would be providing more intensive care case management, including better access to primary care. And finally, with Profile 3, what we could do is to utilize more assertive community treatment, as well as dialectal behavioral therapy made use to those with personality disorders. Notably with high ED users and recurrent high ED users, they should be more correctly identified in the ED, and service plans should also be developed for them. So therefore, outpatient services can be responded adequately and lead them to avoid repeating ED use. So those were the recommendations. I'm sorry if it's a little bit rushed, but thank you so much again for listening. And if you have any questions, I would be more than happy to answer them.
Marie-Josée, can I quickly ask something?
For sure. Go ahead.
I don't know why my video isn't coming on even though I turned it on. First of all, Tiffany, really good presentation. Very, very interesting results. You primarily focused on the primary care use across the 3 profiles. I noticed, and if I read it correctly, that in the first profile, not only is there high primary use, they seem to also be using secondary services to a decent extent, or to even a higher extent than the other profiles. So some of those recommendations about having crisis and after hour services, I feel should be extended, especially where they are already using. So, if people are using services for bipolar or psychosis, part of it is they also have hours that are weekday, like the usual 9 to 4, and they're not available immediately. But I found that very interesting, that it also stops us from making that assumption that many people who are using ED are the ones who are having barriers to outpatient use. Like, it's really important work to highlight that it's heterogeneous and you can't make these assumptions. It's not a question, it's more, I think it was very, very useful. Like, thank you for the presentation.
Oh, thank you so much. Yes, I think it's so important to, kind of take away the stigma and like the assumptions that we always make when it comes to high ED users. Yes, we are I'm in a mental health program, and, there are a bunch of people who, face psychiatric disorders who do use the ED, but that's part of the stigma, and probably the problem as well is that we're assuming that it is only them. In a way that we're able to reallocate resources more appropriately, we can kind of also take away that stigma and also just improve services overall for not only people with psychiatric or mental disorders. So thank you so much for your comment.
So we can take other questions maybe at the end of the presentation. So Morgan will present now. Thank you, Tiffany, again.
Thank you, Marie-Josée. So yes, hi everyone. So as Marie-Josée said, I will talk today about effectiveness of emergency department-based interventions for frequent users with mental disorders. And so this is a systematic review we led last year. And as you can see on the screen, we published a paper based on this work. So feel free to just read the study if you want to know more about it. So I think my colleagues introduced well the issue and the problems we are mentioning here, but just to let you know that for this systematic review, we focused on this main issue, so the quality of care related to emergency department use for patients with mental disorders. So what we saw based on the previous studies we led with Marie-Josée, but also in the literature, we saw that there's a poor access to follow-up for these people visiting emergency department with mental disorders. So few patients receive follow-up, and we could even spot a decline in this follow-up rate in recent years. So again, this is not an issue. This is not only an issue of access, but also of poor continuity of follow-up. It could be before or after ED visits. So we see that in Quebec, but also in international studies. And there's also a lack of adequation of this follow-up that is offered when it's offered to the patient's profiles. And this is also why with the team we led, as you heard, with two previous presentations, we led a lot of studies based on patient profiles to try to improve the adequation of care. So this poor quality of care for those people have a lot of consequences. And among these consequences, you can think about revolving doors, so the fact that we have repeated our IED use, and also poor biopsychosocial results for the patients. So in terms of solutions, we wanted to assess what are the interventions in the literature that are reported and interventions that are dedicated to improve quality of follow-up for patients with MD, with mental disorders, visiting the emergency department. So what we saw and what we found is only one previous review that investigating interventions dedicating to for IED users and IED users with mental disorders. And this review was a narrative review. We also found two systematic reviews which assessed the effectiveness of case management and of consultation liaison interventions among frequent ED users with MD, but it was not ED-based interventions. We also found that most previous reviews considered change in acute care use as the main outcome, but it was some other outcomes were less studies. So for instance, change in outpatient service use or change in clinical or social conditions. So based on those observations, we had one objective with this systematic review. It was to identify and systematically review ED-based interventions and at reducing ED use among frequent ED users with mental disorders, while also evaluating their effectiveness in improving other types of outcomes. So for instance, other service use or also clinical or social conditions. So in terms of methodology, what we did is that we spot relevant studies published between January 1st and April 30, 2022, and we used PubMed, Scopus, Web of Science, Ovid, and Cochrane. In terms of population, we included both adults with repeat ED use, so at least 2 visits per year, and also IED use that we define here as 3+ visits per year for mental health and related social issues. In terms of intervention, we included all types of interventions implemented at emergency departments. And the outcomes were change in ED use after receiving those kind of interventions. And other outcomes were hospitalizations, use of outpatient services, clinical conditions, and social conditions, as I said on the previous slide. So in terms, again, of methodology, we used a PRISMA guideline checklist for leading a systematic review. And we went from more than 16K articles found to a final sample of 12 studies that answered our inclusion criteria. So our main results. So on these 12 studies I just mentioned, we found 4 types of interventions. So 4 studies were discussing care plans. 4 studies, so care plans exclusively. 4 studies discussed case management interventions. 2 studies discussed peer support interventions, and 2 other ones, the 2 last ones, discussed brief interventions. In terms of efficacy, what we found is that among those 12 studies, there were a consensus on the efficacy of case management interventions. All 4 studies we found on this intervention found reduced use of emergency departments, and also an improvement on clinical and social outcomes for the patients who were receiving the intervention. For care plans, we also found significant reduction of emergency department use after receiving the interventions, but results were less consensual for clinical and social outcomes. For the 2 other kind of interventions, so peer support and brief interventions, it was more difficult to have a clear orientation in terms of efficacy. So we couldn't have a some firm conclusion on that. If we want to better understand what were these interventions we found, so in terms of care plan interventions, we saw that, for instance, one focused on the development of a database to generate individual care plans based on EDUs. So it was quite interesting to see that they used like some computerized tools to have individual care plans. On two other studies, we found a similar intervention, but it was more manual, like less electronic, and it was for repeated ED users with MD or with substance use disorders. And we also found a care plan interventions for homeless individuals who were having high ED use. So this was quite interesting to see that targeted population were quite diverse. In terms of case management interventions, so we found that two interventions that were leading a case management intervention, but also embedded with transitional housing. So again, it was more homeless individuals with mental disorders and also with IEDUs that were targeted. And this intervention deployed nurses that served as case managers who also helped patients, individuals with their transition to supported housing. And we also found two other case management interventions studies who described case management, but for also IED users with mental disorder or substance use disorder only. For peer support and brief interventions, as we said, it was less discussed in the literature, but it was still interesting to see what were these interventions. So for the peer support, we saw that these studies and these interventions targeted high users with MD, and it was mainly about peer users that were embedded in mobile teams to facilitate transitional care or to facilitate outpatient care for patients who were repeatedly visiting emergency department. And for brief interventions, it was a bit more specific. Like one was related to a suicide prevention interventions for veterans with repeat EDUs. So it was quite interesting and original to see that. And the other one was a brief intervention, including again an housing component for homeless and IED users. So as a discussion, what we can say is that there seem to have promising interventions in the literature dedicated to improve the quality of follow-up for patients visiting emergency department with mental disorders. We found diverse categories, so 4 categories of interventions. But what we saw, one of our conclusions was that there were not really any intervention that was specific to repeat or IED users, because I'm sure if we got some clinicians among us, we can see that case management or care plans are also interventions that can be given to people with mental disorders, but who are not repeat or high users. We found more evidence in favor of case management or care plans, but also promising results for peer support. Again, it was a small sample, so this is difficult to have a clear conclusion on efficacy. And we also found in these studies that we have a lot of challenges related to the implementation and the sustainability of those interventions. And these challenges are linked to health system issues such as funding or even transition of care and turnover of staff, for instance. And what is also interesting is to see that these kind of interventions are also encouraged or promoted in recent international or Quebec mental health guidelines. So it's quite important to have these kind of interventions in mind and to think about how we can better implement it and evaluate it. In terms of limitations, I will go quite fast. So just to tell you that a lot of the studies were led in the USA. So this is something to consider in terms of comparability. We also have to have a large definition of both of our population, because we included both IEDUs and also repeat EDUs. So again, something to consider. The number of studies was quite small. So this is something I already discussed. And there were very high level of heterogeneity across studies. So in terms of designs, measurements, outcomes. So we couldn't have, for instance, a meta-analysis on this topic. So to conclude, we could say that further research is needed to strengthen the conclusions regarding the efficacy of the ED-based interventions for frequent ED users, especially findings related to outcomes other than ED use. So are those interventions really improving social or clinical condition? This is literature. We don't have literature on that for now. The standardization of outcome measurement could also be improved to have a more firm conclusion on this topic. And we can see that better collaboration between ED and primary and specialized outpatient care could improve services for these patients. Again, as my colleagues, if we want to target some interventions to some profiles, we could say that more intensive intervention like case management or care plans seem to be more effective with people with frequent CDUs, with more complex MD and higher vulnerability levels, whereas peer support and brief interventions may be more adequate to patients with less complex needs or less ED visits. So this concludes my presentation. Thank you for listening, and do not hesitate if you have questions.
Thank you very much, Bahram. Very good presentation. So is there a question? Is there a question for Morgane? And during that time, Morgane, if you can remove your presentation, yeah. And Firas put yours. So just to tell you that the presentation it's recorded, and we can also distribute the publication. There is at least two articles from the publication. Bahram, what Bahram presented, it's published, and also what Morgane present is published, and the rest is in evaluation. So if there is no question, so Firas, you can start your presentation.
Okay, thank you. I'll start sharing my screen. Do we see my screen? Perfect. Hello, everyone. I'm Firas Gaida, recent graduate of a master's degree in public health from the University of Montreal. And today I'm pleased to present in French our study entitled Facteurs encourageant ou limitant l'utilisation de l'urgence psychiatrique par les patients grands utilisateurs de ces services. Ainsi, notre plan sera le suivant. Je vais commencer avec la problématique. En fait, comme signalé par mes collègues avant moi, les personnes ayant des problèmes de santé mentale sont connues pour être parmi les plus grands utilisateurs des services d'urgence. Et d'ailleurs, au Québec, il était estimé que 22% des utilisateurs des services d'urgence en santé mentale en 2014-2015 étaient des utilisateurs récurrents pendant 3 à 5 années consécutives. Les grands utilisateurs des services d'urgence ayant au moins un problème de santé mentale sont à l'origine de près de la moitié de toutes les visites aux urgences pour des raisons de santé mentale, même s'ils ne constituent qu'une minorité. Bon, les services d'urgence constituent l'une des formes de soins les plus dispendieuses et ne constituent pas un dispositif pertinent pour la prise en charge de ces patients. Ainsi, afin de mieux desservir ces patients, il est primordial, il est crucial de mieux comprendre ce phénomène de grande utilisation des services d'urgence en santé mentale et particulièrement ce qui encourage ou ce qui limite le recours vers ces services. Bon, la littérature met en évidence plusieurs études qui ont tenté d'identifier les facteurs associés à l'utilisation fréquente des services d'urgence. Il s'agit principalement d'études quantitatives basées sur des données médico-administratives d'hôpitaux. Peu d'études qualitatives ont exploré ce phénomène et encore moins qui ont examiné la perception des professionnels soignants concernant les raisons pouvant expliquer le recours fréquent des patients à l'urgence pour des raisons de santé mentale. Et au Québec, selon nos connaissances, aucune étude ne s'est intéressée à étudier ce phénomène en se basant sur la perspective des différents professionnels soignants, qu'ils soient cliniciens ou gestionnaires. OK. Ainsi, l'objectif de notre étude était de cerner les facteurs encourageant ou limitant l'utilisation de l'urgence par des patients grands utilisateurs de ces services, définis comme ayant visité l'urgence 3 fois ou plus par année, et bien sûr en se basant sur la perspective des professionnels soignants de différents milieux, urgences, autres services de l'hôpital et partenaires de l'urgence. Concernant les méthodes utilisées dans cette étude, notre devis, le devis retenu est qualitatif basé sur la méthode d'étude de cas de Yin, le cas étant un service d'urgence d'un institut universitaire en santé mentale dans un grand centre urbain de Québec. La population étudiée était composée de personnels de services d'urgence, d'autres services de l'hôpital et de partenaires de l'urgence qui ont un minimum de 6 mois d'expérience et qui étaient soit des cliniciens incluant des infirmiers, des psychiatres, des omnipraticiens, soit des gestionnaires. Entre avril et septembre 2021, 20 participants ont complété 19 entrevues semi-dirigées en ligne compte tenu du contexte de la pandémie. Et nos participants ont été invités à remplir un bref questionnaire, bien sûr, auto-administré en ligne pour obtenir leur profil socio-démographique ou professionnel. Ensuite, les entrevues semi-dirigées ont été menées à l'aide d'un guide d'entrevue couvrant 5 dimensions, comme le profil des patients, l'organisation de l'urgence ou d'autres unités de l'hôpital. Pour les données provenant du questionnaire socio-professionnel, ils ont été utilisés pour effectuer des analyses descriptives afin de mieux interpréter les données qualitatives. Puis une analyse qualitative des données issues des entrevues a ensuite été réalisée et guidée par un cadre conceptuel qui englobe 4 catégories de facteurs. Et ensuite, comme le montre ce tableau issu de nos résultats, l'importance perçue des facteurs encourageants représentés par des signes plus et des facteurs limitants représentés par des signes moins a été comptée à partir de leur mention ou non dans le discours des participants et intégrée dans nos résultats des analyses selon le cadre conceptuel. Passons aux résultats. Oups. Désolé. Pour ce qui est des résultats descriptifs, notre échantillon était majoritairement constitué de femmes et comprenait du personnel occupant des fonctions diverses, y compris des infirmières, des gestionnaires, des psychiatres. Il avait une ancienneté médiane de 14 ans dans leur profession, de 11 ans dans le même établissement et de 4 ans dans leur poste actuel. Et la plupart d'entre eux travaillent à temps plein et se considèrent moyennement à l'aise pour détecter et traiter les problèmes de santé mentale et les problèmes concomitants de santé mentale dépendance. Dans cette partie, on va aborder les résultats de notre étude en fonction des 4 catégories constituant le cadre conceptuel qui a servi à analyser nos données, à savoir le système de santé, le profil des patients, les caractéristiques professionnelles et la caractéristique organisationnelle. En général, nous avons observé que peu de facteurs limitant l'utilisation fréquente des services d'urgence ont été signalés. Il y a également peu de variations entre les déclarations des participants. Je vais commencer par le système de santé et les principaux facteurs reliés au système de santé expliquant le recours fréquent à l'urgence étaient l'indisponibilité de services en santé mentale, notamment un suivi de longue durée, les difficultés d'accès, et c'est surtout aux services de première ligne, notamment l'accès à un médecin de famille ou un suivi psychosocial, particulièrement en CLSC. Et puis les difficultés de gestion de services d'urgence ont concerné principalement l'orientation des patients vers les services ambulatoires qui répondront adéquatement à leurs besoins et ainsi éviter le retour aux urgences. Concernant les facteurs encourageants reliés aux patients, notre étude a révélé des diagnostics et des problèmes psychosociaux problématiques tels que les troubles psychotiques et les troubles de personnalité. Traiter ces problèmes de santé mentale aux urgences peut s'avérer difficile en raison de leur complexité et du peu de temps surtout disponible pour chaque patient. Ainsi, dans la disponibilité des services ambulatoires qu'on a déjà signalés, ces patients reviennent aux urgences. Concernant les problèmes de suivi, la non-adhérence au traitement fait que les patients reviennent plus fréquemment aux urgences et puis le manque de connaissance de certains patients à l'égard des services de santé mentale leur amène à souvent considérer les urgences comme le principal fournisseur de soins en santé mentale. Et les nouveaux immigrants, en fait, représentent un bon exemple pour ça. Et dans ce cas-là, il est important de sensibiliser les patients à différentes ressources disponibles et de les motiver à suivre leur traitement afin de lutter contre la non-adhérence. Les facteurs encourageant l'utilisation des urgences en lien avec les professionnels soignants étaient particulièrement liés à la qualité de relations interpersonnelles et l'expertise des professionnels en santé mentale. Selon nos participants, la mauvaise qualité de relations interpersonnelles s'explique par l'importance de la rotation du personnel dans le réseau ou dans les services, puis le manque d'expertise des omnipraticiens ou des médecins de famille les rend plus réticents à prendre en charge les patients souffrant de troubles mentaux et les incite à les référer rapidement vers les services d'urgence, ce qui entraîne bien sûr une augmentation de l'utilisation de ces services par ces patients. Concernant les caractéristiques organisationnelles, les participants ont mentionné comme principal facteur organisationnel encourageant le recours fréquent à l'urgence, l'insuffisance ou l'insuffisante collaboration entre l'urgence et les ressources externes, mettant en évidence le manque de communication et les difficultés d'orientation ou de transfert de patients. Ces problèmes conduisent à des interventions moins appropriées et moins spécialisées, ce qui fait que les patients reviennent aux urgences plus fréquemment. Les facteurs limitant le recours aux urgences ont surtout été associés aux innovations implantées tant à l'urgence qu'avec les partenaires. Et en effet, peu d'innovations ont été mises en œuvre pour mieux desservir ces patients grands utilisateurs des services d'urgence en santé mentale, à part les plans d'intervention individualisés signalés par ce tableau. Il s'agit de plans qui permettent de guider les professionnels soignants dans la prise en charge ou l'orientation des patients grands utilisateurs au moment où ils se présentent. Dans la littérature, elle recense certaines autres interventions qui peuvent aider à mieux répondre aux besoins de ces grands utilisateurs, notamment la gestion de cas et le soutien par les pairs, mais le manque de déploiement peut être expliqué par l'instabilité du personnel ou la rotation de personnel, ainsi qu'avec le manque de communication peut-être entre les différents acteurs qui pourraient affecter la durabilité des nouvelles innovations. Concernant les recommandations, cette étude a permis de cerner des facteurs encourageant ou limitant l'utilisation des services d'une urgence psychiatrique. Ça ouvre la porte à d'autres recherches qui vont étudier plus en profondeur ces facteurs ou examineront peut-être leur corrélation avec la fréquence d'utilisation de ces services. L'identification de ces facteurs, ça représente le premier pas vers l'amélioration des services destinés à ces patients et vers une réponse plus adéquate à leurs besoins. Certaines recommandations comme travailler sur la rétention du personnel, sur la communication entre les ressources santé mentale ou bien comme le fait d'encourager sur une meilleure adhésion au traitement émergent également de notre étude. En outre, notre étude permet de mettre l'accent sur l'importance de développer davantage d'innovation à l'urgence en lien avec les autres services de l'hôpital et de la communauté, et ceci afin de mieux répondre aux besoins des grands utilisateurs de l'urgence et ainsi réduire leur recours vers ces services. Pour conclure, notre étude a permis d'identifier les facteurs clés encourageant ou limitant l'utilisation des services d'urgence des patients, des urgences, des patients grands utilisateurs de ces services pour des raisons de santé mentale. Globalement, peu de facteurs limitant l'utilisation fréquente de l'urgence ont été signalés. Identifier ces facteurs est un élément crucial dans le processus d'amélioration de la réponse aux besoins de ces patients, car ça permettra de cibler les pistes d'amélioration possibles. Je vous remercie pour votre attention. Et y a-t-il des commentaires, peut-être des questions? Voilà nos références qu'on a utilisées dans la présentation.
Merci beaucoup, Firas. Very good presentation. So we have maybe a few minutes to take questions. So for Firas or for any one of us, maybe we can take like five minutes. So are there any questions related to Firas' presentation or any of the presentator? Don't be shy. No questions?
Je vois que Carlos a une question, mais son micro est fermé.
Carlos was one of our partners from this research.
Yes.
I didn't thank our partners. So this research, I think it's very important. It's a big missing for me. So a big thank to our partners. We collaborate with 4 CIUSSS and they really help us, particularly for the data collection of the 300 patients. So a very big thanks. And Carlos really helped us quite a lot. So thank you, Carlos. Go ahead.
Okay. Hello, everybody. Sorry I missed the first 8 minutes. I have just a couple of questions because I noticed that in the different categories, for example, people that consume drugs, people that have mental health problems, but I noticed at least if we're looking just at our place, I know the study was done, a lot of the studies were done in the United States and might not reflect necessarily our reality here. But was there any thought given pertaining to our legal clientele and the fact that often sometimes we have to trigger legalities to bring them back to the hospital, and that usually means the emergency room. So that would be my first. I wanted to know, what was your thinking behind maybe not having them involved in your studies, or maybe it just was under mental health and substance users, and just a little clarification relating to that.
This is a very good question. Unfortunately, we don't have this information in our research. We don't have this kind of information in the usual administration database that we have. So I have this information in some of my research with Addiction Treatment Center. It is included in their system, which is called the CISSD, so the administration database of the Addiction Treatment Center. So we are looking at that for this specific research with those databases. But in the Institut de Statistique du Québec database, Médico-RAMQ, there is no information on this. So the demographic variables that we have, it's mostly sex and age, and also material or social deprivation, which are related to the territory. And we had this survey of 299 people, but unfortunately, we didn't look at this question, but that could be a very interesting question to look at in our further research. So sorry about that, but we didn't look at this specific clientele. We didn't have any information about this clientele. So do you have other questions? You said your first question, and after that,
yeah. I'm just going to ask one more because I don't want to hog all of the questions. It's just pertaining to one of the presentation. We mentioned types of interventions, and one of them was case management, and then there was this part that mentioned making the link with transitional homes. It's a service that maybe is more common in the United States. As you know, seeing the context here in Quebec, it's so difficult to get any housing for any one of our clients. But I would have thought, like for case management in terms of intervention, I would have thought that maybe the case manager being present at the ER, the case management being there at discharge time, the case management having an appointment to see their client 1 day after discharge, 2 days after discharge, I would have thought that would have maybe have had an impact. So I don't know if that was also thought about.
So maybe I will ask Morgan response. Yeah, go ahead.
Yeah, exactly. Thank you, Carlos, for the question. So actually what you just described was exactly what we found in the studies linked to case management. So what I just wanted to say in the presentation, and maybe it was not 100% clear, is that in addition to what you just described, so all the classical, if I can say it like that, case management features, we also saw that for 2 of the studies, the case manager were following people from ED or ER to a transitional housing solution. But exactly as you said, they were making a follow-up after discharge. They were making follow-up to other primary care providers. So yeah, this is exactly what you just described. And also maybe to add something on what you just said with transitional housing solutions or whatsoever. With Marie-Josée team, we also did some other and Marie-Josée is still currently doing other research on transitional housing, and we saw very interesting results in terms of effects, decreasing ED use or improving satisfaction. So this is also something we need to consider when we think about intervention for IED users, even if, as you said, and I said it as well, funding issues are one of the main issues that led those innovations that are not implemented. So yeah.
Yeah, just to tell you that those literature that we look at in the Morgan research was very close to what we call housing first. So, and for sure, for this people with the homelessness population, it's very important to link them with housing solution. I can just add, it was very astonishing, even in Quebec, in the site that we look at, or in the literature, there were very few intervention that we found aimed to reduce this phenomena of high IED user. Even if those people, we have a lot of statistics saying that those people consume almost half the resource of the emergency department. There is not a lot of things that target this clientele, unfortunately. And we also look in our research, but they didn't present anything about that. There is kind of benchmark that for sure people are going to the emergency, people are hospitalized, and they are quite vulnerable after this services is acute services and need some follow-up in the community. So we also published maybe 4 articles on that, looking at benchmark on if those people had follow-up care after they visit in the emergency department or after hospitalization. And unfortunately, also there is, just a minority of people that who goes to the emergency department and receive follow-up care after in 1 month, 3 months. Those are usually the benchmark that we are looking at, and there is very few people receiving those follow-up care in the community. So there is a lot of improvement to do at this point at the emergency department. I know that there is also those in the actual action plan. There is 3 new innovation target to improve emergency department, but in those innovation, there is no preoccupation in terms of high IED users. So Sylvia, sorry about your name. Probably pronounced it not good. So sorry.
Oh, no problem. Just maybe 2 questions, based on, in the first group again in Tiffany's, I was thinking about the fact that some of the people who are already using services, primary and secondary, sometimes the ED use is with the involvement of their current team. So I'm thinking about when I used to coordinate PEP, sometimes the patient isn't doing well and you don't feel comfortable with them returning home, and you tell them and they agree as well. Is there any indicator in the system that allows you to tease out which ones were sort of they themselves initiated, or they came in the evening when the outpatient clinic wasn't there, versus those that were actually, so sometimes the case manager would actually walk with the patient to the ED, and this would still show up as an ED visit, but it's a slightly different ED visit because the solution of providing aftercare services or crisis services is not, they actually have access to outpatient, but it's happening because it doesn't feel, maybe home-based treatment would be good for those people. But I was curious if there's any indicator in the system that shows those types of ED use that actually are mediated by current treatment, outpatient treatment teams.
This is a very good question. Maybe I will answer this. If we look at, because we did quite a lot of research looking at IED user, and I can say that, overall, those people do not have a lot of follow-up care globally. So because we look at intensity of follow-up care that were provided to those people, in terms of GP, and we also create like a proxy of family doctor that we do not have in administration data. We look at specialized care like psychiatrist care in our 300 survey. We try to understand if those people had intensive case management or assertive community treatment, but in globally, those people were not with a lot of outpatient services. Some had services, so it's more maybe the profile that Tiffany present, the profile one, I believe. So it's why also we did this profile, because we believe there is, different types. There is a lot of people presenting at the emergency department without follow-up care. So they have kind of an incident cases of mental disorder. So we have this group, and I think the team at the Douglas de Relance, what we call de Relance, the Relance is targeting people without mental disorder provider and try to give them some services and transfer them to outpatient care. So I believe this kind of services are very important because there are quite a lot of people presenting at the emergency department without a mental health provider in the community and with kind of incident mental disorder. But there is also those phenomena, very high chronic user of emergency department. Those receive more services than the rest. It seems that those services are not sufficiently. But in our research, like Eric asked, we have just in the survey, because we have the hospitalization database that we can look if how many people have intensive case manager, or even though we can, in the questionnaire we ask how many people had also intensive case manager. But we have assertive community treatment also at the hospital, and there were only a few people with those kind of, and even Tiffany said, case manager at large, she said a majority, but in fact, I think Tiffany, it's 58%. So, there is a lot of people without those case managers, even if they have a lot of problems. They are also isolated, a lot of stigmatization. I think in our 300 people that we follow, almost half people have kind of high stigmatization. So it's unfortunately there is few intervention for those people at this point.
Yeah, and I can also build on the fact that in the literature reviews too, like unmet needs and just like those nuanced, as you said, it's just like how did they even get to the ED, and like that transition period is really not like well written or well understood in the literature. It's really just not mentioned overall. There's definitely a gap in between like quantitative research and qualitative research, and like using a database you get more patients to be able to analyze, but in the qualitative you're maybe able to ask those like more specific questions with like the how did they actually get there. And I think right now we just need to fill that gap, and we're definitely trying to figure out ways to do so and understand it further. So it's a good point.
So maybe we can take a last question if there is a last question, because it's almost 1:30. So thank you very much for all. Also, I have Marie-Hélène. So you can speak in French or in English as you wish.
Oui, bonjour. Moi, je voulais juste donner un commentaire, dans le fond, par rapport à la stigmatisation puis des omnipraticiens. J'ai eu une rencontre l'année passée avec les infirmières du GAMF, le guichet d'accès aux médecins de famille. Puis ce qu'ils m'ont nommé, là, c'est qu'une des problématiques, c'est que les omnipraticiens veulent pas avoir les clients qui ont un problème de santé mentale. Fait que ceux qui en ont besoin beaucoup vont être ceux qui vont être longtemps sur une liste d'attente, malheureusement. Ils ont comme un quota. Ceux qui ont des problèmes, exemple d'anxiété, TOC, etc., ils vont les prendre parce qu'ils sont pas tant de gros besoins, mais ceux qui ont une schizophrénie, dépression ou bipolarité vont être longtemps sur une liste d'attente. Malheureusement, j'ai essayé de bouger les choses, puis c'est vraiment plus de l'enseignement à faire aux omnipraticiens, puis dire il y a une équipe, fait qu'on peut les aider, puis on est là pour les soutenir, mais c'est très difficile.
Ben, en fait, c'est vraiment vrai ce que vous dites. Aussi, dans notre recherche, on a monté des proxys d'avoir un médecin de famille, puis c'est à peu près le double de cette population, soit avec des troubles mentaux ou des problèmes de substance, qui aurait accès à un médecin de famille. On sait au Québec, il y a à peu près 20% des gens qui n'ont pas de médecin de famille. Dans nos recherches, c'est plus autour de 40%. Effectivement, on avait fait, nous, beaucoup de recherches sur les médecins de famille et leur rôle en santé mentale. C'est sûr qu'il y a vraiment une déficience. La littérature le dit aussi, c'est des patients. En même temps, quand on regarde, surtout les belle enquête là, de CISSS qui vient de sortir, les résultats 2022, c'est quand même les omnipraticiens qui suivent le plus la clientèle en santé mentale. Ça, il faut le dire, là, c'est quand même parce que sinon, il n'y a pas beaucoup de services. Là, eux autres, c'est vraiment la porte d'entrée. Donc, quand on fait des enquêtes populationnelles auprès de la population pour leur demande où ils reçoivent des soins pour leur santé mentale, c'est quand même les omnipraticiens qui donnent le plus de soins. Mais on sait que les omnipraticiens sont mal à l'aise avec la clientèle ayant des troubles mentaux, particulièrement complexes ou des troubles concomitants. De là, l'importance aussi de travailler dans les équipes, c'est d'avoir des équipes multidisciplinaires de soins dans les GMF, infirmières, travailleurs sociaux, psychologues, etc., que ça peut beaucoup aider pour le suivi des patients ayant des troubles mentaux. Donc, merci. Je vois qu'on a dépassé notre heure. C'est déjà quand même pas pire qu'on a encore un certain nombre de personnes. Donc, un grand merci à vous. Puis, on va mettre, donc, on va envoyer la présentation à ceux qui, on va mettre la présentation sur les sites web de Douglas. Puis, c'est possible aussi, on pourra mettre l'ensemble de nos publications. On a quand même notre équipe écrit peut-être une trentaine d'articles quand même sur les urgences qui inclut le Douglas comme site dans tous les recherches. Alors, merci beaucoup. Merci à toute mon équipe. Très belle présentation. Merci, au revoir. Merci à vous tous.
Merci.